organized for today's session, which is basically focused on AI at the intersection of bench and bedside. Basically, it's around health. We will talk a bit about the research part and also the practice about this. So I think in 55 minutes, 50 minutes is absolutely impossible even to touch what exactly is happening across the world, or let us say even within India. But nevertheless, I think we'll try to do justice with the time. So my name is Dr. Rakesh Kumar. I work with Lavani and Global. I've been in the government and started the government for more than 30 years and also here with the chief advisor. I've been CEO of this foundation and now I'm working with the same brothers, Lavani brothers, with their company called Lavani and Global. We have a very esteemed panelist here. What I do here is that I request them to self-introduce themselves and just talk about a bit, what exactly we're doing in the domain of health and care. So I'm handing over first to Meena Moktali, who is the co-founder of Preventive Technologies. Over to you.
Thank you so much, sir. It's a pleasure to be here today. My name is Meena and my co-founder Kaustubh. I started Preventive 12 years ago. The idea was to enable access to cervical cancer screening, which is necessary everywhere in the world. Women are supposed to undergo a cervical cancer screening every 3 years. And developed countries have been doing that successfully because they have the resources. But unfortunately, in countries like India, lack of infrastructure, lack of the number of experts to handle so much of population is hindering from screening to happen to a certain extent. I think we have less than 2% women who undergo screening, whereas many of the developed countries have achieved double-digit numbers. So the mortality around the world is quite high, especially in countries like India. Every 8 minutes, one person dies of cervical cancer. And around the world, I think it is somewhere around every 2 minutes. So 350,000 women die every year. So how do we prevent this? The idea was to create a digital tool which will enable clinicians to capture data from the field and also to analyze it faster. But while doing so, we understood that the idea doesn't stay limited to just creating a handheld camera device. That's something that we created first. But also to be able to analyze those images correctly enough so that it could give real-time results. So we built an AI by collecting data ourselves through our device over a long period of time, and now we have an AI which is 92% sensitive, and it provides the result within 30 to 40 seconds. Since 2019, we have commercialized our devices in the market, and more than 1,000 sites have been using that now. Till date, we have screened more than 4.5 lakh, that is 450,000 women. Just this year, we celebrated 8,000 lives that were saved because of the Smart Scope. That's the name of our device. These women were identified at pre-cancer stages and could not have been done with any other test that is out there in the market, like Pap smear. So that's the kind of impact that AI is creating in the Smart Scope.
Thank you. We have next speaker, Dr. Vidyani Suryadevara. So she is a faculty at the Innovation Center at the Stanford University.
Firstly, thank you for inviting me here. So I'm a faculty in the Department of Genetics at Stanford University. So I've been a scientist for the last 12 years and been a bioengineer by background. So my focus was also developing new imaging techniques to non-invasively detect various diseases, as well as finding new therapeutic targets and using the latest multi-omic approaches. So we've been using AI to kind of interpret all these large data sets that are generated from the epigenome and then proteomics, transcriptomics, and also recently we are able to have spatial multi-omics, which is all thanks to the new technology. And with the fast growing pace of AI, we are also integrating it to be able to quickly interpolate all these data sets. And my main focus is biology of aging senescence. And senescence is like a very vast subject and it's very heterogeneous. Even across the same in the organ, each each different cell has different senescence markers, and this heterogeneity is very complex. And so we are using AI tools to kind of decipher these phenotypes. And my other focus is also comorbidities and multimorbidity in aging. And for example, Alzheimer's. So people don't die of Alzheimer's per se, though they die of other complications like cardiovascular effects and falls and fractures. So we're leveraging these AI to kind of integrate the imaging technologies as well as omics to kind of understand these comorbidities, where we can track them early on and even prevent the further onset of cognitive decline. And then share more about how we are using AI for healthy aging.
Thank you, Vidyanji. I'll go to Rahul Pandey, who has an extensive experience of working in the ministry and also now working in the World Bank as a senior program manager. Over to you.
Thank you, sir. Good afternoon, everyone. First of all, I think walking in the corridors, you must have seen everyone seems to be really excited about what we are going to do in AI, right? And hope you found your places for your coffee and food, and also navigate through the rooms as well, which is pretty easy, right? Just coming to the session. I think if we talk about what World Bank does, several of you might be aware of it. It's a multilateral development institution which is putting financing on the table, and it's a kind of partnership which we build with the government. It's not, the World Bank doesn't do anything on its own in isolation. Over a period of time, I think there has been a very significant amount of investment, and I was chatting with my colleague earlier, and we learned that almost 4 billion plus US dollars have been invested on foundational systems of how digital health systems can work. And in the morning we were in a couple of sessions where industry leaders, experts, and all of them were talking about AI modeling models are as good as the foundational systems available. And the foundational systems are a very simple term to speak, but if we get into the details, they go from everything from a typical digital infrastructure, internet infrastructure, to creating some kind of interoperable framework, having information exchanges, unique identification. We get into all those elements of foundational system. Without that, and then the more important what comes over here is the data. How do you train your AI models and system, and the data, that to good quality data. Now the World Bank investments, while the digital health investments, etc., work on core designing tools and system, the other investments of health system reform actually look at some human angle to it. Like the data quality is not just the tool decision, it's also the human decision. How do those at the front line actually create and enter data in the system and take it forward. So all of these investments together in India and elsewhere, we are trying to create some kind of foundational framework so that any kind of AI models and tools, if you want to scale, implement and scale in a state kind of setting or a country kind of setting, that has something to work with. Finally, I think one of the things which we have been working very kind of serious about, that the partnership is very critical if we want to make sure that the AI models really give us some tangible results. And the partnership is not just between the government and multilaterals, it's about the private sector, it's about industry, academia, non-governmental organization. I can give examples where the tools designed, developed and tested by non-governmental organizations are now being implemented pan-state to 100 million population to 50 million population as well. So we can talk more of some of this, but that's the fundamentally what we try to focus as part of the bank.
Thank you, Rahul. Thank you for your introductory remarks. I'll go to now Maulik Choksey, who is Global Director of Access Health International, and he's a professor, a research professor. Over to you, Maulik, for your initial comments.
Thank you very much, sir, and thanks for having me here. I represent the organization Access Health International, and we are a health system design organization. So let me break those words, health system design. Today, most of the people might have heard what ABDM, Ayushman Bharat Digital Health Mission, right? And now we are listening AI big time for past a year and a half. The first conversation of ABDM started in 2016. It was announced 2021 by our Honorable Prime Minister. But the work of ABDM, the first conversation on National Digital Health Mission started in 2016. And we have been part of the process right from 2017 till 2021 till that day when our efforts saw a policy framework and an implementation framework. And that's what we do. Currently also at 4:30 in the evening, we are going to announce our strategy, AI strategy for health. Right? Again, this piece of work is not something that's happening overnight. There has been a year and a half efforts going on in creating that strategy. And we are part of the process of creating the strategy. Now, what does it mean? If I take ABDM as an example again, we had 150 consultation in a 2.5 year time period. Each and every stakeholder's perspective was taken into consideration when this strategy or National Digital Health Mission was drafted. And similar efforts are currently going. And when we talk about AI specific, who are the people who are going to get affected by AI, right? Who are the people who are going to use AI? How are the people going to use AI? I think so when you create a strategy document, each and every element needs to be part of consultation, and you need to have a framework to address those things. And we, Excel International, are happy and proud to be part of this process, primarily supported by various development partners, but that's what we have been doing. We also do something else. So let's say ABDM got announced, right? What is the impact of ABDM? It got announced in 2021. Today we are 2026. Almost 5 years are getting over. So what has been the impact of ABDM as far as provider are concerned, facilities are concerned, consumers are concerned? And similarly, we have already started working on implementation research frameworks for digital health. We work, and now we are working on AI. So if you want to measure the impact of AI, how are you going to measure the impact of it? People talk about interoperability. Interoperability might be something that a bureaucracy might be looking at. But for my bedside, privacy is something that I am looking at, right? So this is what we tend to do as a health system design organization. And I gave digital health and artificial intelligence as domains, but similarly we work on healthcare financing, we work on pharmaceutical policies. We did some work with Nitya very recently, making sure we had this huge kind of cough syrup crisis in our country, right? How do we make sure that our systems are agile enough to kind of detect those kind of stuff, so when something happens, we're able to respond it. So we work across 3 or 4 primary domains: financing, pharmaceuticals, and digital health, as well as people's health movement. And thank you for having me here.
Thank you so much, Malik. I think before I go to the second round of questions, I'm sure I'd like to touch, I request you to touch on certain areas which are the key challenges we are facing across the world. So friends, when we talk about key challenges that we are facing in the AI system, we find the infrastructure gaps are all over, because recently we have entered in the global south, and especially the African region. You look at the infrastructure, whether it is absolutely available, or I would say it's missing. We talk about capacity building and HR issues. Do we have right set of people? Do we have those kind of capacities built over there? I think still is. What about promotion of the local and the local innovation and the solutions? Again, we are talking in general, but what about the local solutions? I think they are going to be more important. They are going to play an important role. What about the ethical and your social implications? When you are using AI, do we have those kind of ethical and social implications? I think we have to look into that. We do lack, collaborations, knowledge sharing. Again, it's one of the major gaps that we always find. What about data? I've seen, when we are talking to certain governments in the Africa region, especially East and West both, data is missing. So can we really afford to have those kind of AI solutions created? In that situation, it's going to be like garbage in and garbage out. So is it possible that we start, And lastly, which I feel, one of the major challenges that we are facing is the whole of LMIC. The world is flooded with pilots. Now, how to take these pilots to scale is, in my view, one of the most challenging situations currently what we are facing, especially in the global south. Pilots, why we fail? I think we all know that wonderful pilots are across the world. They're beautiful, you'll find that they're very smart motors, they always give a promising accuracy. The nice dashboards are available, but when it comes to scaling, whether we are able to scale them up, I think that is an important area. So I'll request you when you get time, when we have the second round, please try to touch on this. So I'll go to Ms. Veena Mokhtali. In your view, Veena ji, what does responsible deployment look like, especially in the health area? And in case you can touch upon the human in the loop. In healthcare, I would say, and any domain you look at, the human in the loop is going to play an important role. So we're able to really talk about this, that will be useful.
Sure. That's a very important point, because as a clinician, when a clinician is using AI to make any decision, I think the information that comes out of the AI also has to come with a lot of credibility, and that's where I think the point that you made earlier about garbage in, garbage out also comes into the picture. So of course, your AI needs to be trained on the right kind of data with the right kind of inputs, but also it needs to have certain sort of explainability. So in our case, because the AI was to be used by nurse midwives or health officers at the grassroots level, uh, there was always an element of who would take the decision of treating the woman if she is found to be suspect positive. And we thought that since a clinician is not really a part of that decision making at that point, we should give an opportunity for, let's say, an onco expert to review these images or review the cases that are identified by the AI as a suspect positive. So we consciously kept a human in the loop before a decision for treatment is made. Although the WHO does have protocols about see and treat for something like cervical cancer, So what that means is, for those of you who perhaps don't have any idea about the cervical cancer is one such rare disease where even at a very early stage, at a pre-cancerous stage, there are treatments available which can be performed even at point of time. So that means there are tools available which can treat these pre-cancerous cells of the uterine cervix. So there has been a concept for almost 20 years where the WHO is also promoting that nurses can be taught to treat these precancerous lesions. In reality, however, that has not happened, because although the nurses are taught to do visual examinations, while treating somebody, they feel a lack of confidence. And that's where we thought our AI adds a great value. By giving them information, by giving them that simple decision making that, if the AI says this is a red case, that means this woman needs this particular type of treatment and she may be referred for further treatment. Whereas if she's, the case is a brown colored case, that means she has a low grade lesions and she does not need an aggressive treatment. So this kind of a communication is all that these nurse midwives needed at that point. But the actual decision to treat the woman or what kind of treatment should be given is left to the clinician. So we have included a remote review system in our platform where the same images which are captured on ground are also viewed on the cloud platform, where the clinician gets to see them, score them, and accordingly schedule them for the treatment.
Thank you, Venaji. Thank you so much. I'll go to now Dr. Vidyani. You are a top-notch biomedical research scientist at the Stanford University. What about AI applicability in the biomedical research? How do you see this? And second, I always say that, how best we can ensure that the AI solution should go from lab to the field. Because at times you are just working in the labs and creating those kind of pilots, but ultimately how they are going to be more beneficial to the public is a question. But how do you see that, as a biomedical research scientist?
So as I mentioned earlier, we're leveraging AI to kind of decipher all these multi-omic imaging large data sets. And coming to how we deploy it for the benefit of public good. So my main focus now, after being in biomedical research for so long, is preventive healthcare. Like, there's so many, people are talking about that they can cure cancer, but nobody really talks about the side effects. So from the last 3 years, my focus has shifted to how we can prevent the diseases as we age and increase the health span of the aging population. So we're working with the Worldwide Fingers team based at Karolinska Institute, Sweden, and Stanford Global Health. And it's 5 different things. I think it's for everyone to remember: food, physical activity, sleep, cognitive exercises, and cardiovascular health. And what we are trying to do is develop region-specific interventions and even more leverage AI to develop personalized interventions. So AI will get inputs about what our health conditions are and what we like to do. For example, I talked about these 5 things. In the physical activity, there might be somebody who are already physically active. There's some people who might be not finding time to go to the gym. So for those people, we have designed something called exercise snacks, where we can go to the we can just do these things for 10 minutes at our desks, and these have benefits of going to the gym for an hour. Similarly, cardiovascular health, sleep, and all of that. And in cognitive exercises, some of us like to play chess, some of us like online games. And since we are all from India, we are very culturally rich, and our music and dance forms encompass many of these cognitive aspects, physical activity as well as social interactions. So we are training these AI models to kind of incorporate our health data as well as our individual choices and develop personalized interventions. And we also are developing models to first risk stratify the individuals for disease, and then they can focus more on these interventions. And every day when we wake up, this AI tools will provide us what are the 5 different things we need to do. And eventually we'll also build digital libraries for different populations, because we are such a diverse country, and if we can make it more fun and to incorporate these lifestyle choices and increase the health span of the country as a whole.
Thank you so much. Thanks a lot. Rahul, I just come to a very pertinent question to you. Again, we have been talking about pilots and, scalable pilots. Because unless you integrate these pilots in the systems, any system you're talking with, the health systems, with agriculture, education, any domain you talk, I think the most important part is how best you can, basically the change is not going to be technical, it's going to be structural. And that requires a lot of funding support. I always say that 90% of sensitivity of these AI pilots, still I find that I don't know, use this word useless, but at times you'll find that why let us say if it adds to an extra burden to the frontline worker, it's not of any use. Similarly, if it lives outside the system, so unless we integrate these pilots within the system, it is not going to be of any help to us. If it requires perfect data, because in governments and you go to any country, especially I'm talking about the global south, data is not going to be perfect. So our solutions have to be created which are quite aligned with so-called imperfect data which is available in the country. And let us, if we are not able to sustain these pilots, once the donor is gone, then also I think it's a useless exercise to happen. In your view, being a multilateral donor to the governments, how do you see, how best these particular, especially World Bank is helping and supporting the governments in scaling up these solutions?
Thank you, sir. Indeed, a great question. And this is a very interesting set of panel as well. We are having a very specific technical conversation on ideas and then how to really scale them. I think there's something, a great idea is not great in itself. Unless a good idea can be scaled, a good idea is a great idea. A great idea which cannot be scaled given all the constraint, it will remain in a very small island of innovation and probably will not give us the dividend what we want to have. So I think that's something, and the scale, I think we use the scaling up very loosely as well. Sometimes we say we need to scale up this pilot, we need to scale up this idea. The scale up doesn't happen in vacuum. There are bureaucratic challenges, there are wills, there are resource constraints, there are issues around data, standards and all of that which drives how exactly you scale certain things. So in our point of view, there are 4, and I will not get into the detail, but 4 fundamentals if we really want to look at how do we want to take something to a scale or something which is at a scale and we sustain that. And the first one is on these things, the data standards and digital public infrastructure. I think that's fundamental, that's basic. Without that, even if we think of anything, and that includes a lot of things, I think if we get into detail, we can have a whole day session on that, but Ayushman Bharat Digital Mission is trying to look at some of those aspects very clearly, and how do we really create those frameworks to make sure the data system, DPIs and the platforms are available. The second thing is, let's not talk about, okay, this is the idea, let's scale it up. Is that idea can be plugged in an existing platform, that DPI, can it be interoperable? Okay, let me not even talk interoperable over here. Can it really exchange information with 2 existing systems of the government or in the large public sector providers which can connect to each other? I think that's what's going to make it really work. The third, which we don't speak as much in every conversation, is the workforce and institutional capacity. Again, institutional capacity is a very loaded word. There are 15 different dimensions of institutional capacity, and again, we can have a long chat on that. But the workforce capacity and institutional capacity together will make sure that what we are trying to bring to the platform will really go forward. And there, one area which we have seen, if you talk about the frontline workers primarily, We feel that we have developed, its user interface is good, we have provided it to them, they can use it. In our personal experience working with Anganwadi workers, one simple tool required 9 months of constant training, month on month, to make sure they were able to use 40% of the UI of that particular application. So I think investing on that, if you want frontline workers and users to really use it, is going to be very critical. Finally, the financing has to tie to the readiness and the outcome. We cannot just put money. In the morning also we were having conversation, and it's of the government money. Also the World Bank is technically not a donor. It's a lending organization which is putting the money and the government is returning that. It's a technically government money itself, if I be very frank with it. So any money which is coming from the taxpayers, which is being used for some of these things, we cannot just invest just because there's a great idea. Can it really link to the platform? Is there a DPI system in place? Is there workforce and institutional capacity we are building on? If together all of those four investing, then investing in the tool and technology will really give us dividends. So I'll probably stop here, but if there are further clarification questions can come to it.
Thank you, Rahul. Thanks a lot. Now, going to our friend Monik. Monik, how do you find, intersection between AI and research? What is it?
I answered at two levels, right? My first two panelists come from biomedical, and I'm a biochemist myself. So I think so. I remember when I was a student. I'm from MS University of Baroda, and it was one of the best libraries. And I spent number of hours even sleeping in library. At that time, if I want to do a research paper, identifying a publication or an article from Nature or Lancet was a job in itself. Right? I think so. AI has made that life much easier. Right? So I think so. If I start looking at basic science, my first prima facie is what is known. So I don't invest in what's known. I focus on what's unknown. And I think so. In research perspective, AI is a fantastic tool to elucidate what is known, and henceforth I can focus on what's not known. Right? But this is primarily at a biomedical sciences, and then what she said, I think so. I know, in vivo setting, in vitro setting, I can see what chemical interaction happens, kind of stuff. It decreases my time. So, if I look at that perspective, research perspective, I think so. My basic biomedical research, the time taken, the accuracy of research, I think so. It has gone very fast. But I wore that hat for a very small period of time of 5 years, and then I became a public health researcher. And I think in public health research, there again are huge opportunities. And I will focus on what you asked us to do challenges. Firstly, in LMIC, you did mention we have got data, but we also acknowledge that the quality of data and the standardization of data is not good enough to create LLMs right now. And henceforth, there is an inherent bias on the LLMs which are created right now. But having said that, so decision support system might take some time in evolving. But process level AI dependent algorithms could be very fast. So if I say I want to decrease out-of-pocket expenditure in medicine, one of the way of decreasing out-of-pocket medicine is provide services. To provide services, as Rahul said, we need money. There are a lot of issues in the way money flows from federal government to state government, or state government to district government to block level. AI can help there, right? That process engineering can really work with AI, decreasing the kind of blocks that where money is getting stuck. And that itself can result in a lot of kind of net benefit as far as health system is concerned. Similarly, if I say, a lot of people, 40% of Indian population is in urban area, right? If I say in Delhi, people start talking about pollution, blah, blah, blah. There are around 7 ministries who are working together, have got money to focus on health within their domain. If we get algorithms of where the monies are, where the money is stuck, and how the money flows out, I think so there is a huge efficiency gain that we can get as far as AI is concerned. It can give data visualization, it can give effect on kind of what kind of decisions needs to be taken. So I think so at a research perspective, also it helps in seeing that what's working, what's not working, what needs to be tweaked, and how what Rahul mentioned of kind of departmental convergence that can come into picture. So I think so there is a huge scope at a biomedical level as well, and there is a huge scope in terms of how the health system could be strengthened in taking decisions. And the last bit, I would say, the biggest kind of government-supported health insurance scheme we have got, or PMJ. If you want to see that how many frauds are happening, how do we prevent that fraud? I think so. AI, there is huge scope of research in those segments to bring efficiency as well as thing. And I would take a word from Ajay and kind of, if you want to shift ambulatory care from let's say hospital to home-based care, I think that's what the data talks, and AI can help in really augmenting those kind of processes and making sure that there is an efficient health system in delivering care, which saves money as well as time. Thank you.
Wonderful, Maulik. My boss always says that the world is going to be divided into two types of people. One who knows AI, another who doesn't know. I think the times before us are absolutely challenging. So I think we have no option but to go for this. I was trying to understand. I worked for multiple years, more than 3 decades in the government given system. I think the only benchmark that I established for any successful pilot was whether it is replicable or whether it is being accepted by the government. I think that has been, and you like it, but most of the occasions I will find that more than 60%, 70% pilots which are being established and done by different agencies, whether within the UN system or NGOs and all, they remained projects, within those files, and they ended there only. But I think in AI we can't afford to have that kind of situation. We need to be absolutely prepared to see that what sort of pilots we do, though still, there will be chances that those pilots won't really work. But how best you can ensure these pilots, to get scaled up. I was looking at, Bhagwani AI in India, that we have been able to, it's a huge team. I was looking at, how they have been able to succeed in their own ways. Because India has got, in the Ministry of Health, they have got multiple national programs. And very smartly they have aligned themselves, starting from the co-creation to the scale with the government. With government data. Look at the TB, malaria. There is a huge national TB program. We have got malaria program. We have got maternity. We have got high-end, spectacle, Kelly. So I'm sure the wisdom in the room is absolutely fantastic. I'd like to hear from you also. But as a last round of questions, your closing remarks on this. What should you want to say and talk about this? After question and answer, maybe I'll try to add a few of my observations and concluding remarks. So how should we start? Should we start?
Yeah, and that's a great responsibility to kind of summarize. But yes, of course, and this was a very insightful session, by the way, right from research to financing and of course analysis, so that it becomes an integral part of the healthcare system. How AI will add value is a very, very important topic, and I think the point that you made about pilots being designed in such a way that AI eventually, or any innovation for that matter, eventually becomes a part of the system is very, very important. And that has been my experience as well. I agree with the point, so I'll perhaps end my thoughts by saying that it is the intent which has to be clarified when the pilot is designed. Because pilot is like an element. Everybody has their eyes closed. The government expects something from the pilot. The innovator is expecting something else from the pilot, and perhaps the beneficiaries or the people themselves are expecting something else. So unless everybody has the same kind of objectives out of that pilot, and the communication is made in the right manner, I think even innovations like AI, which may have a great promise, which may have been built on a lot of data, also will find it difficult to be a part of the system. So having that intent clarified in the beginning is very important.
Thank you. Yeah. Yeah.
As reluctant I was about when AI started, when it was like hugely elevated, but now I'm pretty confident that AI can take us from reactive care to predictive and preventive health care, and I can see great potential in helping increase the health span of the individuals, not just in India but across the globe.
Thanks. I would put the HTA framework for all of us to think. Does it work? Is it safe? Is it cost worth it to put it. I think those three, if we really have the HTA approach even on this one, I know it's very difficult to be a very black and white answer for some of these things. I think, but we need to know whether it works, it has potential to be scaled up, it is cost effective and all. I think that is something we should take for sure. The second thing is, and this is something, let's go back to 2000s when technology started coming into our health sector, at least the health sector to help us service delivery and all that. I think since beginning, one of the things which I always probably did not like personally is this thinking that probably bringing a digital solution or an AI system or any new technology will solve the problem. The problem is solved by people who are there. They're providing services they need to solve. It needs to be an enabler. It cannot supplement and replace what the system can deliver. Till the time we don't acknowledge that, the fight and the tussle between the both will continue to happen. They will push and pull. So I think that is the second thing I want to take home, put the message over here. And the third, which is very, very critical, is especially currently the AI models, they are as good as what gets fed into those models itself. So data systems, are we doing enough on our data quality research? Are we putting enough resources and support to make sure that basic building block of what the data, where the data gets, data doesn't create it in air. The service delivery becomes data point itself. The day we start hitting that in our mind, every time we think of data, the data is not coming from thin air. There is a service delivery happening, which is becoming a data point, and that service delivery to data recording needs to be resolved. So I think these 3 points would be my final takeaway on this. Thank you.
Fantastic. You did touch base on human in the loop, which is very important. Okay.
And at this point, as a researcher, right? A researcher moving towards Viksit Bharat 2047, I think so. We are in a good space. I think so. India AI Coach is making a lot of anonymized data sets available. So that's in good direction. Once they can make available. ICMR, National Health Authority, Ministry of Health are working on anonymized health data being accessible, both at a disease level and at a state level. We have got some old kind of outdated GBD data, burden of disease. But I think so, if I look at a researcher, right, so there are good data sets which are coming out in market which can help us in kind of solving real world problem. But again, as you have kind of directed us, I'm being careful that currently, because the data systems are not that rich, I think so, there has been a tendency to use synthetic data, and I think so I'm also very mindful about researchers when they are using synthetic data and training their models, they are being transparent enough to let people know what they are doing, so that the onus on also comes back on researcher to make sure they make those points very clear, the kind of data sets they are using for training their AI models and creating algorithms. Thank you.
Thank you, Malik. I think it's just 5 minutes for, we can take, 2-3 questions, or multiple hands, but how to start? I don't know. Here is quick and...
So I'm a pulmonologist from Hyderabad. So you mentioned about tuberculosis. So a lot of people develop complications when they are not monitored properly, and then they drop out of the treatment. Non-compliance will be there. So has there been some work on this trying to improve the compliance using AI to avoid complications, predict complications and improve the compliance?
So I won't be able to reply to you, but I'll be happy to connect, with the experts who are working in this particular field on any solutions. So I'll take your details and come back.
Thank you.
Thank you for the opportunity. I'll just summarize all the panelist questions and main points. So cancer care, prevention are the core enablers, and then you talked about the district level implementation. My simple question is India's primary healthcare ready for the AI implementation?
Rahul? Yeah. Thank you.
It's a great question. It's always ready. There is no switch off and on. I think that we have to accept in a large public sector kind of working. We cannot have a on and off switch. Now it is ready, now it is not ready. What makes it ready, and whether if all the primary health systems, all the districts are the same pace, that differs. I think that differs on multiple parameters. We have to take it from this point of view. And I'll give you a very real life example. When first time a frontline worker-led digital job aid was introduced in 2015, when they were and I'm talking about the Anganwadi workers, those who are not from India, don't know, they are semi-literate or illiterate frontline workers who have never even held a feature phone in their hand. Everyone said that they are not ready. It took around 9 to 12 months of effort to make sure they get trained. They get again and again, multiple segments were trained, they come back, they go to those services, come back. Once it was done, they were the first ones to start using the application and take it forward. So I'm taking an example to tell you that the readiness doesn't happen just because we have created the infrastructure. It happens when we invest on those who want to use it, and if they are confident to use it, the day they start using it, things will become more kind of.
Thank you, Rahul. Yeah. Just two more questions, please, not. Otherwise, outside we can always.
Good afternoon, everybody. My name is Nishant and I'm an educator in AI. So my question is that we have a huge data and we want our AI to be fast, right? But in aviation and in clinical field, there is a term in AI, hallucination. Then how can we deal with it? Like it's a kind of.
Yes, I think so. As your data sets grow and they are trained properly, I think so the noise will go off, right? But again, most of the AI systems are self-learning AI systems, so it's going to be a continuous challenge, right? It's only the good quality of data that's going to be, good quality last data is going to answer to your question. Until we get that good quality last data, which keeps on evolving on itself, right? And still some noise will remain. I think so. Let's accept the limitation that will bring in.
Sorry, I'm just intervening. When you say good quality data, right? Data doesn't tell itself that it's good quality data, right? So it's the field ops which are very important, which Rahul, I think you mentioned, that if you don't have field ops, you don't have laws to actually mandate field ops to make sure that the correct data is actually being entered. How are you going to settle that? So hallucination is always going to be there, but it's not going to evolve by itself. Sorry about that.
Last.
Please. You can just take the mic.
So my question is, so at what level we are there sincere efforts to build large-scale Indian multimodal datasets, healthcare datasets to train foundational models like that integrate imaging, culture nodes as well as the structured lab data? And how do we design the feedback loop from the clinicians to the training data pipeline?
So for the lifestyle interventions project, we are generating the data. We're starting off with as a pilot in Andhra Pradesh and Hyderabad, and even in Bangalore, the Center for Brain Research Institute. So they're acquiring longitudinal aging data, and this being done thoroughly with imaging and omics both integrated. So we'll have in-house data generated accumulation.
Thank you. Two questions from this side. Sorry, we have to. Madam, first.
Very interesting panel. Thank you very much. I have been working in the health data, very innovative approach to really use open innovation to really solve the local problems and use large congregations like Kumbh Mela to really actually serve as a sandbox for creating that baseline data. This thing is a MIT sponsored support system for Kumbh Mela at Nasik. And we'll be driving the same initiative again in the next Kumbh, which is 2027. And I'm very keen to really understand how the government start using it. Actually, ABDM Ravi Kadimji, who was heading the Nasik Kumbh, he moved to the ABDM, and that's how it actually got implemented in the governmental systems. What more can we really do to really bring in the efforts of Stanford, the efforts of MITs, and the efforts of this thing to really, really take a leap?
I'm sorry if I understood your question correctly, but I think so. Once the data sets, I think so, ABDM is creating at least health infrastructure data sets, right? And if there is an emergency kind of stuff that's coming in, the data sets are very, very helpful in kind of making sure that right information is flowing at the right point without losing time. And I think so that energy could be extended in terms of the repository helping using for disease surveillance and being climate resilience preparedness. So I think so as we move forward, it will come up. If you ask me what's happening today, I don't have an answer for that. Thank you.
Yes, last. Very last.
Yeah, actually, for the past few centuries, there is an increasing intelligence of microbial organisms versus human intelligence. The frequency and the virility has been getting, frequency has been getting higher, virility has been getting higher, and as a collective human beings, we don't have a collective intelligence. World Health Organization, all global institutions are crumbling. Domestic sovereign institutions have a limited time frame. The parliament has 5 years, so we are looping in the 5 years tenure of human collective intelligent effort. Forget about AI. Do we have a collective human intelligence institution to mitigate the future pandemics, which may recur quite frequently from centuries to decades now?
So I think your question is at a very intellectual level. We should have a very kind of open conversation on this. I'm not sure I'm the right person to answer that completely, but two things I want to put over here. I think in any kind of democratic setup, and you rightly said that the world order is changing, a lot of things would change, like how exactly people can support each other. Unless the data sharing cross-border is very open, a lot of these kind of pandemics are very difficult to even predict and even kind of prevent from. So how does that happen? If all the countries are open doing it. Now, no one has really control on how the countries will behave, as you rightly said, how things are moving in that direction. What I personally feel, and this is nothing to do with where I work and what I do, I think this constant state of chaos we are in, the only way forward is we organize that chaos somehow. I don't think there's a very finite way of answering that question, because I can give you 15 examples where we try to, with government, we try to set up regional data sharing platforms and mechanisms and systems. It didn't work out for multiple reasons. Neither X country is at fault nor Y country is at fault, but there are individual preferences, realities which people want to put in. So I think those realities will be there. The AI systems can, and the last point is where AI systems can help, and I'll close with an example. Right now in India, the surveillance is more reactive. Something has happened, you go detect, outbreak detection, put a team and all of that. There is a huge amount of gold mine lab information data available routine basis, which is for provision of IPD and OPD services in hospitals. If we put a large language model very importantly and analyze that very clearly, it will give you a heat maps in real time that probably something is wrong in this geographic area. All the PHC, CSC and district hospitals are picking high markers of infection. Something is happening over there. Can we look into it? So the AI models can really give us some of the solutions which we have not been able to do earlier, but whether it will solve all the problems you mentioned, I really don't think so. It needs a lot more effort.
This is the last question, sir. Dr. Vidyan. Ma'am, you have mentioned like lifestyle modification for chronic diseases like cardiovascular diabetes. So I'm working in monarchs.ai. So my question is, what are the most important patient factors needed for making personalized lifestyle modification for the patient? Let us take gender, socioeconomic changes, everything.
So we have my first focus was dementia, and then we have developed a Indian specific dementia risk prediction risk score called CADE. So it took into account BMI and then education, sex, and then it also took into consideration total cholesterol. And so these were some of the basic parameters we began to work with. And as more complicated it gets, we can add more parameters like smoking history and then renal complications and all the diseases.
Okay, thank you.
Thank you. Okay, so I'd like to thank and you all. Just a final, couple of points from my side, because we have to ensure that AI works, for the larger game. So I always say that we should stop celebrating these kind of experience. Rather, we should celebrate the integration, but it really happens. We need to design for the constraints and not for the ideal condition. Because if let's say we don't have good data, it doesn't mean that we should stop doing it. Similarly, we need to build these AI solutions for the users and not for the users. I would like to say that AI doesn't fail because it is too efficient, but it fails because it is not open. We need to really remain grounded. And finally, I would like to mention here that, and this is a quote which I took it from somewhere, it says that when the AI becomes invisible, embedded, and trusted, and boring, then it is fully functional. So I think I leave you with these kind of thoughts and ideas, but thank you so much for being a wonderful audience and also the panelists. Thank you.